all that is saying to be telling you all. But it's nice to see a lot of you, almost 50 of you logged in for today's session, especially in the beginning of the week. I'm sure you've all just finishing or about to finish your day's work. So I appreciate you all and a warm welcome. And like Radha said, I'm a pulmonologist who has also trained in palliative care. And my main focus is to focus on non-cancer palliative. And today I will be talking about how and why we all must think of palliative care when we think of advanced respiratory conditions. Please do put your queries on chat as and when I'm talking. Radha will have a look at it and flag it off. It's best to sort out the queries or whatever doubts you have as you get it, because at the end we might not be able to solve all. Also, I can take a break to drink some water. Second thing, the more you interact, it will be more interesting. I also end up learning a lot from you all, and it will be vice versa. So without wasting any more time, I will share my screen. So please feel free to put in the chat, and I will really appreciate if we can, keep interacting. So the focus of today's talk is respiratory palliative care. And the first question is, why should we actually be talking about it? So if you see the number of Indians who are affected by non-cancer or non-communicable diseases, as the government sets the statistics, you see a whopping almost 50% of Indians who are affected by the non-cancer or the non-communicable diseases, which are the lifestyle diseases. To start with diabetes, hypertension, dyslipidemia, cardiac, cerebrovascular, and respiratory conditions. Now, in the respiratory conditions, tuberculosis still is very high on the cards, COPD because of domestic pollution and air pollution and cigarette smoking, as well as other lower respiratory tract conditions like interstitial lung disease. So in India, we have, yes, we do add 1 million new cancer patients to the list every year. But having said that, 50% of Indians are suffering from non-communicable diseases for a long period of time. And these communicable diseases, if you know well, I'm sure all of you do, are not curable. Right. So if you sit back and think of all the conditions that you have treated, be it gastro, neuro, cardio, respiratory, or even renal, think of the conditions that you're able to cure 100%. So which I can flip it the other way around and ask you all, which are the conditions that we as doctors are able to cure 100%? Please put your answers on the chat box and think about the 1/3 which we cure, 1/3 which is controllable, like diabetes, blood pressure, asthma, etc. And there is a 1/3 of disease which is incurable. So if you see from all the conditions that we see, 2/3 require a lot of hand holding. We're only able to control these patients and their symptoms and let them lead a life which is relatively symptom free, wherein we focus on the quality of life. We are not able to cure blood pressure. We are not able to cure diabetes in many patients. So which are the conditions which we doctors actually are able to cure? I would like your answers on the chat box. Radha, please have a look at that. Coming to specifically the respiratory conditions, COPD, interstitial lung, and tuberculosis are all on the rise. So the incidence of all these conditions are on the rise. And unfortunately, TB is now complicated by XDR TB, multi-drug resistant TB, totally drug resistant TB, and extremely drug resistant TB. So we are facing with the challenge of treating difficult cases of tuberculosis, where the treatment is expensive, it lasts for longer time, and the side effects are more, and the patient, unfortunately, being in the productive age group, definitely needs handholding for the patient and the family. So it's important to realize with all these chronic diseases on the rise, and most of these chronic diseases not having a cure, they are going to be the ones actually attributed or who will benefit by palliative care. I can see that there is a chat but I don't think anybody has answered. So can I please encourage you all to infections? Excellent. Thank you, Bethes. Am I spelling your name right? Beth Sheba. Yes, so infections are the one we are able to cure. We are able to return the patient to full quality life. You have included TB. Unfortunately, TB is both completely curable and completely incurable these days. So TB can be actually also a part where it can benefit with palliative care. Thank you for that answer. I really appreciate, because nobody else really answered or didn't want to answer. But please keep the chat box going. So coming to understanding why we need, palliative care for respiratory conditions, quickly, I'm sure, I don't know whether all of you have seen this graph, but typically today we will focus on graph C. And if you see graph C, these are patients with chronic organ failure. It could be applied to any organ. But consider I'm talking about respiratory conditions today. So let's focus on, say, COPD. So this patient of COPD is diagnosed to have the condition at the age of 60 or 65, and he continues to lead a prolonged period of time with high symptom burden. Unfortunately, from the diagnosis to death, it could be 10 to 15 years or even more. And these 10 to 15 years of his is frequently punctuated with dips, infective exacerbations, hospital admissions, worsening of COPD, and the patient never really returns to normal quality of life. And what we see as pulmonologists in the acute care settings is when the patient comes into the ICU. What we do not know, and we never even bother or not trained to know, is how this patient is returned back to the community and the family. Is he able to walk on his own, talk on his own, care for himself, eat for himself, change his clothes? So this forms the quality of life of the patient. When he becomes more and more dependent for activities of daily life, his quality of life is definitely dipping. So what are we doing about that? Do we even bother to ask the patient how his life has changed since the diagnosis? Similarly, interstitial lung disease, or even for that matter, congestive cardiac failure, when we do not have a cure for these conditions, and when these conditions cannot be completely treated, we really need to handhold these patients. The other biggest challenge of respiratory conditions being integrated with palliative care is that they are not perceived as life limiting. So 7 years ago, when I was just a pulmonologist, I used to never tell patients of COPD and interstitial lung that I didn't have a cure for them, that the medications I'm giving them is only for symptomatic treatment. So they live in hope, right? For them, it is their body, their life, and they live in hope that the pulmonologist is giving them treatment for their condition. Because it is important for us to be telling the patient, we really need to think of this picture. So this interesting paper says that falling off the skyscraper is like falling off the chronic illness ladder. As the patient is falling, so the manner in which the patient falls, the manner in which the patient lands depend on the way he falls. So as the patient is declining, if that is punctuated by unhurried, sensitive, iterative, difficult dialogues, difficult conversations, patient and the family has enough time to prepare themselves, enough time to ask questions, and enough time to expect what is the natural course of the disease. Now, as a pulmonologist, I have seen more patients with COPD. I have seen more patients with interstitial lung disease. So whose onus is it to explain to the patient in the patient's language what he is in for? It is our onus to foresee and foretell. Therefore, at an appropriate time, we need to sit the patient down with these caregivers, because the entire family unit suffers through this chronic disease trajectory. And we need to explain to the patient what lies ahead. And it could be plan A, plan B, plan C. And it's important that we do that so that they get enough time to sit back, analyze, come back to you and ask you, okay, so what happens when A happens? What happens when B happens? And what happens when C happens? So we can help them come to a decision and conclusion of how they would like to be treated in any emergency or whatever the situation may be. But it cannot happen outside the ICU. Typically, I get referred when the patient reaches the casualty with a type 2 respiratory failure, breathless, carbon dioxide 80, oxygen levels are 40, and or 2 centimeters away from the endotracheal tube, I get called. That is the wrongest time to talk to such families. So please remember, the earlier the integration. So now what we have learned over the years is my pulmonology colleagues call me when there is still some curative treatment going on. The important thing is to be identified and introduced as a part of the pulmonology team. So, as the curative intentions or curative medications fail, that is the time we can transition to palliative care. So, the transition is smooth. It's not like the pulmonologist abandoning, saying, I cannot do anything, go to palliative care. That shouldn't be, because it's very dejecting for the patient and the family. If you are introduced early on, you can provide holistic care. As you all know, palliative care looks after total pain, not just physical, emotional, psychological, spiritual, financial, which is very important in our country. So it is important that that transition takes place, so that patients are transitioned into palliative care in an appropriate time. And the beauty of palliative care is it continues to end of life and the bereavement phase. It doesn't stop with the death of the patient. So we look after the family also, because this family is the reason the patient was alive for 8 to 10 years with good caregiving. And it's a huge void for these patients, when for these family, when the patient dies. So, okay. So it's important, therefore, to integrate at a correct, appropriate time. Because very often hospital consultants say the minute we mention palliative care, patients feel they're going to die, or doctors feel they're giving up. So hence, we need to integrate it at the right time. How do you decide the right time? So in UK, they actually researched this question. So if you're sitting as a doctor in the clinic and you have a patient who walks in your mind, think, will I be surprised if the patient is not alive in the next 1 year? If your answer to the question with your clinical acumen is that you will not be surprised, that is the time to integrate proactive palliative care. So, not everybody in your OPD or everybody in your patient list will fit into this. Okay. So, just to simplify this question, what is the criteria? The criteria, as explained by two very good papers, which Pallium will share with you, which is the gold standard framework, which is the patient referral guide by NHS, as well as a Blue Maple document by Manipal University, actually gives each chronic condition and the indicators to refer to palliative care. For respiratory, it is typically elderly people, recurrent hospitalization, requiring MMRC, which is modified medical research level of breathlessness to 4 to 5, on continuous oxygen, drop in lung function test, comorbidities which are uncontrolled. So patient needs to have any two of the following to be referred to palliative care. So it makes you think that when such a patient walks into the OPD, think in your mind, will I be surprised if this patient is not alive? If the answer to that question is no, you need to refer to palliative care as a part of your team, so that it's not that you have finished your job and the palliative care takes on. It is a shared care for the patient, where the primary pulmonology and the palliative care team completely takes over the care for the patient and the caregivers. Any questions, doubts, thoughts, or any remarks? So these are the two documents which Pallium India will share with you, which clearly gives you the indications for when to refer to palliative care and when specialists should actually wear their palliative care hat so that it benefits the patient. The other the way of looking at it is, in the West, they have researched where in a particular ward admitted with patients, 80% of cancer patients received palliative care, because historically cancer was the reason or the condition where palliative care was started. And unfortunately, even today, physicians, healthcare professionals believe that cancer is the only thing that should get palliative care. Please remember, palliative care is a need-based science. It is not diagnosis or prognosis based. Everybody copes differently with the diagnosis. There are some people, if you diagnose them to have stage 4 cancer, they'll say, okay, I will see what best I can do. While there are some patients with stage 1 cancer who completely get demoralized and crumbled and they cannot handle the situation. So people are different, and that's why palliative care is need based. If a particular patient and family is not coping, irrespective of the diagnosis or the prognosis, palliative care comes in handy. So it's, please remember, palliative care is not just for cancer. Palliative care is not just end of life. And it is a need-based science. The other important thing is that when you talk of palliative care, you also need to realize that, you know, it's not necessary that all patients of palliative care will eventually die. There are some patients we discharge from palliative care, but the hand-holding is very, very important. And please, that's why even the West, the statistics are staggering that non-cancer patients hardly got any palliative care. And what is the downside of that? The non-cancer patients, even if the condition was incurable, they unfortunately received more aggressive treatment. Their distressing symptoms were not acknowledged and treated at the end of life, and they ended up having more CPR. So please remember again that when you have a patient not coping with their diagnosis, family not coping, that patient needs palliative care. Okay. So even if you admit patients of COPD with acute exacerbation in the ICU, if you see the statistics, 50% are almost readmitted to the hospital. What happens when you are doing ICU duty? You just want the patient to be survived. So we think our victory or our end point is survival. What we completely miss out is quality of life. We really need to focus as quality of life vis-a-vis quantity of life. It should not be Sada Yushman Bhava, but it has to be a good quality of life, good with respect to the patient. What the patient enjoys doing, he should at least continue to do a little bit of that. So for him to enjoy his life. So please remember that the mortality, even after admitting such patients to the ICU, is close to 70 to 80% after 5 years or 3 years. So unfortunately, non-communicable diseases, the course is very unpredictable. It's a very roller coaster. Sometimes you say the patient is going to die, but the patient comes back from type 2 respiratory failure. So what does the patient and the family feel? I can go to ICU once, I can go twice, I can go thrice, I will keep coming back. That's not going to happen. And nobody budgets the suffering. Suffering is something that there is no bill for. The amount of physical, emotional, financial, social suffering that these patients and the caregivers go through, nobody asks. The other important thing nobody asks in the country is, what does the patient want? Medical ethics. Autonomy is the first pillar. We never sit and ask the patient, this is your condition, these things might happen, this is how much your survival is. What do you want to do? What do we say? In my experience, you should go to ICU. In my experience, this ABG, you have to be put on the ventilator. We really need to realize that the amount of people who survive from the ventilator with such an advanced disease is very, very low. Okay. So any questions, any thoughts? Am I clear as to why we need to integrate palliative care in respiratory conditions? I hope I'm being clear and I'm audible. Okay. So once you...
Yes, dear. No, I've been keeping track of the questions and things, nothing so far. And there's a reply that they are in track
Akira
with
has
you.
said yes, ma'am. Thank you. Some people
Yes.
are at least are awake and responding. I hope I'm not putting the rest to sleep. So anyway, all of you are doctors, right? So you know how to evaluate the commonest symptom of respiratory medicine, which is breathlessness. I don't need to tell you that take a history, clinical examination, a chest X-ray, ECG are the basic things, even probably an echo. But the two things that we commonly miss is the blood gas and the pulmonary function test. It is very important to realize, because today what happens is, even when the patient enters a casualty with breathlessness, probably the first thing we do is, pulse oximeter, but that's not enough because it doesn't tell you carbon dioxide. And why is carbon dioxide level important? Because type 1 failure respiratory is only when oxygen levels are low with a normal carbon dioxide. There is no change in the pH. Type 2 respiratory failure, which is very critical, is when the oxygen is low and the carbon dioxide is high, where we say patient is in respiratory acidosis. So it's extremely important to recognize this, because the prognosis of type 2 respiratory failure is much worse than type 1 respiratory failure in the long term. Okay. So what we are not trained to ask patients of breathlessness. So if I may ask, when your patient of breathlessness comes to the OPD, what do we always ask? Is your breathlessness better? Is your cough better? Are you better? So we end up asking close-ended questions where the answer for the patient is yes or no. And most patients want to impress doctors, so they never say no that easily. What we fail to elicit from the patient is how this breathlessness has changed his life. So imagine if a patient of chronic obstructive lung disease or interstitial lung disease is so breathless every second, every minute of the day after day, week after week. He's housebound, he's oxygen bound, he needs help for activities of daily living. If you can think of the things that he must be going through, he must be frustrated, angry, sad, anxious, panicked, fear of death all the time. Correct? So these patients are emotionally extremely disturbed. And there is enough evidence to suggest that as the patient's physical activity declines, the mental health also declines. And this is something that you and me are unfortunately never trained to ask in our history taking. Are you coping? How are you feeling? Or what is it that you have given up because of your breathlessness? So it's very important. We always ask, are you breathless? Are you better? If we ask the patient, what is it that he or she has given up? That is what opens the Pandora's box. I cannot play with my grandchild. I cannot talk to my friends on the phone for long. I cannot do my gardening. I cannot eat with the family in the dining table. I cannot go to the toilet on my own. For them, these are the things which completely demoralizes their dignity. And we in palliative care want to restore dignity, comfort, and respect for these vulnerable patients who are so dependent on others and their caregivers for their day-to-day activity. There's some chat sessions, but I don't know. I think it's just attendance. Okay. So therefore, it comes to another very interesting slide here, which actually describes the vicious cycle that our patients with advanced chronic respiratory diseases are caught in. They are breathless because of their pathophysiology, which is work of breathing, poor elastase in the lung, their, parenchyma is fibrosed. So whatever be the pathophysiology, because of the underlying pathophysiology, patients are breathless. Imagine if a patient is breathless and he decides to walk a bit, he gets more breathless and that makes him more anxious. So he panics, there is a panic attack, there is fear of death. So there is a mental component to breathlessness. When a breathless patient is anxious, he then decides not to move at all from his chair or bed because he says, even if I walk 2 steps, I'm going to get breathless. So let me just stay put. What happens to muscles when you don't use them? Anybody? When you just keep sitting in a chair for 1 year, 6 months, what happens to the muscles? Exactly. So
Some responses are there.
very good. So it's basically when you don't use the muscles, you lose the muscles. So here we have a patient who is so breathless, he's anxious, and now he's deconditioned. Therefore, even walking 2 steps to the toilet or even changing clothes makes him completely breathless because his body is not used to it. Here comes the beauty of palliative care with its multidisciplinary team, where the pulmonologist can focus on the breathing, the psychologist focuses on the thinking, so that the anxiety, what is making him worried, what is the problem, get to the bottom of it and address it, acknowledge it and address it. And the physiotherapist, with the help of pulmonary rehab, allows the patient to function for activities of daily living. Now, tomorrow, if you and I decide to run a marathon, can we run the half marathon or the full marathon tomorrow? Yes, no? Will we be able to run? No, excellent. So we need to train our body and mind for the marathon, right? Every day we get into graded incremental exercise. Similarly, what the physiotherapist does is gets into graded exercise for our patients so that he does the activities of daily living with less and less effort. For the patient, playing with the grandchild, talking on the phone, eating dinner with the rest of the family, or going to the garden is his marathon. So we need to focus on the patient goals, not on what you and I can do. We need to focus on what the patient gets joy out of. And that's what we do with the beautiful integration of palliative care, where the pulmonologist then focuses on what he is trained for. The psychologist does his job. The physiotherapists do their job. The volunteers train the caregivers so that everybody feels supported. And this multidisciplinary approach actually helps the patient break the vicious cycle. So it's very important to recognize what our patient is going through. And that is what is called as the next slide. Yes, conditioning, correct. So what we call, therefore, we need to understand this term of chronic breathlessness syndrome. This was coined only in 2017, where a patient is breathless and continues to be breathless despite maximum medical treatment, which is typical of advanced congestive cardiac failure, COPD, ILD, pulmonary hypertension. When this breathlessness starts affecting his psychosocial, emotional health, that is what is coined as chronic breathlessness. When the patient is totally disillusioned, disheartened, doesn't want to do anything, that is where the we call as chronic breathlessness syndrome. And irrespective of the duration, these patients really need to, audio is not clear?
Yes,
Radha,
it is clear.
it's
Yes,
clear?
It is clear.
Yeah, I
It
think
is
please
clear,
check your
Rajam.
net. Please check your,
See, for
yeah,
whomever it is not clear,
yeah, please check your
maybe,
network.
no, you can just sign out and sign back in. Many times that might help. Sangeet, you just make sure that they can sign back in. Lakshmi, Prabha,
okay.
just sign out and sign back.
Okay, so chronic
It's
breathlessness.
clear now.
Yeah. If you recognize the fact that the patient is in this, then you will address the patient's distress by integrating palliative care into this. The fact that patient feels hopeless, disheartened, the family is stressed, they keep coming back to hospital and expecting miraculous cure out of an incurable disease. That is when they really need to be integrated with palliative care. And what do we do for management of breathlessness? It is not just dishing out of prescriptions. Non-pharmacological aspects are extremely important interventions in managing patients with any kind of palliating any kind of symptoms. What are non-pharmacological? So for patients with breathlessness, you focus on loose clothing, well-ventilated room. Do not crowd the patient with all kinds of caregivers. See to that the patient is wearing in a correct position. Some people feel good with propped up. Some people feel good with, leaning forward, right lateral, left lateral. Whatever the patient is comfortable with, we need to assign that particular position. The next thing which is very important is distraction. So something like acupressure, acupuncture, music therapy, pet therapy, etc. Because these are patients who are always breathless. When they become more breathless, we really need to teach and train the caregivers of how to distract this patient. One very effective way is a battery operated handheld fan. Do you all know that if you have a patient who's acute on chronic breathlessness, say with COPD or ILD, and you just blow cool air onto the patient's face, there is enough research to suggest that the respiratory center by serial MRIs becomes calmer, the respiratory rate becomes less, and the patient automatically becomes less breathless without any medicine. Just handheld fan. If you Google search battery operated fan plus breathlessness, you'll get a host of articles where just that 50 or 60 rupee fan makes a big difference. Next is you also teach the patient relaxation techniques, which the physiotherapists teach. And then you also help the patient plan his life. So if he enjoys a particular thing, you need to help him plan, prioritize, and pace his activity. So example I can give is if a lady likes to cook, you tell the lady's assistant or caretaker to provide everything, to keep the vessel, the vegetables, the masala, the oil, everything, so that this lady can get the pleasure of putting everything together without walking to get each of the things. So the joy is that she's still able to make that particular dish, but she's not done everything. She's done with good assistance. So please remember, talk to your patients about what they want out of life. Everybody is different. Let's try and get to at least 50% of what we can give what the patient wants. We don't have a magical wand where we make everything disappear. We are not God. But at least we try to find solutions. We at least accept and acknowledge that, yes, it can be very distressing. Yes, I can see that this is not easy for you. So if you acknowledge that, at least a lot of the patient's concern is also alleviated. Then, of course, the pharmacological treatment, which you all, I'm sure, are great at for breathlessness, includes antibiotics, steroids, bronchodilators, nebulizers, and all of that. So, one word of caution about oxygen therapy. Please do not use oxygen for all breathless patients. So it is not a panacea for breathlessness. Oxygen should only be used when the saturation is below 88 in the pulse oximeter. Abuse of oxygen is also something we saw in the phase 2 of COVID, where people needed the oxygen, didn't get it because there was no oxygen available. Second thing, giving oxygen unnecessarily causes nascent free radical oxygen damage to the lungs. So do not give oxygen unindicated. Oxygen does not relieve breathlessness if there is no hypoxemia. The second thing that I would really like to highlight here is morphine. How many of you have heard of morphine for breathlessness? Nobody?
No, there is Atira has said that.
So
Yeah, I
you
think
have
she's the
heard.
only person so far.
Thank you. So it's good that somebody has heard of morphine. How many of you have access to morphine? Shruti also has said yes. Great. So morphine is a narcotic. Okay, great. So morphine is a narcotic usually used for cancer pain and usually used for severe cancer pain according to the WHO ladder. But very small doses of morphine, start low, go slow being the mantra. So we start with 2.5 milligrams of morphine, SOS, followed by twice a day after proper assessment of the patient. Okay, when the patient is taking all his medications correctly, and is defined as chronic breathless, MRC classification 4 or 5, breathless at rest or very minimal exertion, that is when you start the morphine. Please remember that morphine will cause constipation at any dose. You must prescribe laxatives, otherwise the patient is going to hate you for causing constipation. Plus, you must give them diet which is rich in fiber, because if a breathless patient gets constipated, that is a recipe for disaster. So please prescribe morphine with laxatives. Second thing, how does morphine act? It acts centrally, it reduces the respiratory rate, it increases the work of breathing, and it also acts like an anxiolytic. So it has multiple effects to reduce the respiratory rate. So patient who's on 35 to 40 comes down to 28, 30, etc. So he can improve his tidal breathing. And in all these years, one has never seen death due to use of morphine because of respiratory depression. Even pulmonologists say morphine in breathlessness, you want to kill the patient. If morphine is used in a right dose, reviewed correctly in select patients, it makes a wonderful difference to the patient's quality of life. Because what are you dealing with? You're dealing with terminal COPD, terminal CCF, terminal ILD. What do they need? They just need to take a few breaths, which is of peace, able to do small things that they enjoy. And hence, we improve the quality of life. So the examples that I have seen over the years is the patient comes in a wheelchair for the first visit on morphine, actually takes time to dress herself, wear earrings, put a lipstick, and walk to the OPD. The patient feels joyful when they say, I can actually step out in the dining table and eat with my family. So these are the goals that give them joy. And what we try to do is get some life into the patient's years and not just keep adding years to their life. So you need to understand from where the patient is coming, what is important to the patient. And we will be sharing these slides. This is a nice algorithm to say how to start the morphine. When you start subcutaneous and intravenous morphine in opioid naive patients, if you suspect anxiety, you can add a medium-acting benzodiazepine. If you suspect panic, then you can add a long-acting benzodiazepine. And please remember, you continue all the medications that is required for the patient for his underlying condition. So that does not stop. Addition of morphine is to focus on increasing the quality of life of the patient. So it's a wonder drug. There's again enough evidence to suggest, especially in COPD, trials are not very convincing in interstitial lung disease, but you always will review. So if the patient is not improving, you need to go back and see why the patient is continuing to be breathless. Maybe he needs more psychological intervention or physiotherapy intervention. Okay. Any questions so far? I'm happy to stop sharing and answer the question on morphine and come back to this. Any thoughts, queries, why, anecdotes? Anything?
See, anyone wants to unmute and ask also, no? Feel free, because that may be better. No? As I always say, this is a luxurious platform for all of you. So please utilize the opportunity. That is the best way forward.
Anybody would like to ask something about morphine, or do you all have access to morphine? Regarding getting the access to morphine, please ask
No.
Pallium. Pallium will help you with getting the access to morphine, especially if you've done this course. Yes. Anuradha has asked, is there any absolute contraindication for morphine for respiratory patients? Thank you for asking. Very, very important. So again, you need to think of which patients will you want to give morphine. These are patients who are desperate, who are breathless every second. You want to improve the quality of life of patients. So there is really no contraindication for this. The side effect, yes, is constipation. When you start the lowest dose of 2.5 SOS followed by 12 hourly, followed by 8 hourly and 6 hourly, we never need to exceed more than 15 to 20 milligrams in 24 hours. Unlike pain, where there is no ceiling dose for morphine, in breathlessness, if your patient is not improving with 20 milligram, we do not keep going escalating. Okay. So mechanism of action of morphine is this. It's centrally acting. It's anxiolytic. It reduces the respiratory rate. So it improves the tidal breathing and reduces the work of breathing. That's why the oxygenation improves. Patient feels less breathless. It is not a respiratory depressant in 2.5 milligram doses. So we use very, very small doses, Dr. Anil. When you use large doses, then it causes respiratory depression, but we never reach there. Like I told you, we do not escalate doses more than 15 to 20 milligrams in a day. If the patient is not responding, you need to go back to your books, go back to the patient, find out what he's doing with the morphine, what else is bothering him, what is the issue with him, and then take the help of your team. So any more queries or questions about
I
morphine?
think, I hope, because Dr. Rajam has once again explained the mechanism. So I think, hope Dr. Raj, things have clarified, because there are many myths. So it'll be better. Is it clear what she has explained? She did explain during her session, and now what it does. It reduces the work of breathing. It reduces the rate from 45 to 25 when it happens. The tidal volume improves. So those are the clinching factors.
So, for example, another way of thinking about it is, suppose a patient is breathing that breath, that imagine he will not be able to do anything with that, not complete a sentence, not get up and walk. That becomes, so we are not completely removing the cause for breathlessness. We are just reducing the sensation of breathlessness. So the patient feels better. It is not that the COPD or the ILD, and the doses we use are so less that it does not cause respiratory depression. This is one of the biggest deterrents to use morphine and deprive patients of a good quality of life. So it's important to emphasize this in this platform, because there are close to 70 doctors here, and they really need to be convinced that if evaluated correctly, a patient with chronic breathlessness, with breathlessness at rest and minimal activity, with a modified medical research council grade 4 and 5, should be given a trial of morphine along with physiotherapy, along with his regular medications, along with counseling and family support, because there's a huge opioid phobia amongst doctors, amongst patients and caregivers. Why? I don't have pain. I don't have cancer. Why are you giving me morphine? This is the questions people ask. So we need to be convinced so that we can convince patients and caregivers. There are some
Just one thing I thought of adding, Rajam. See, exactly the way you demonstrated made me think. There is something called as dead space. Okay. That is very, very important. All of us have done medicine. Okay. Whatever specialty or whatever we are today. So what is dead space? That oral cavity, trachea. When they do that 45, the actual gas exchange or tidal volume, nothing is reached. Everything is just wasted in that dead space. It's just in out, like a panting, what we say. So if the breathing is made norm to near whatever is there normal, that eases. So that is something to be understood. And then there was a question about other drugs which
yeah,
you
so
could
unfortunately in our country, we have only morphine sulfate available. Where Radha works in the UK, there are more molecules of morphine, opioids available. In this country, unfortunately, another thing that gets sold or propagated by pharmacists is the patch, which is also an opioid patch. But in palliative care, because we are high touch, low tech, we do not advise patches for multiple reasons. We are a tropical country. The sweating which happens in this country, not everybody can afford to sit in an AC. We don't know how erratic the dose is released from the patch. Second thing, once you put the patch, it starts releasing morphine 8 to 10 hours later. So for those 8 to 10 hours, the patient has no relief. Third thing, on the patch, after 12 hours with the circulating morphine, if the patient continues to have symptoms, then you don't know how much dose to give or not give because you don't want to overdose the patient. We are very, very careful to give only that much which alleviates the symptom. We want an awake patient who is comfortable, not dope off the patient. So that also is something we don't know. And the last thing is once you rip off the patch, still there'll be some circulating morphine, and we still don't know, therefore, how much is the circulating morphine in order to achieve comfort. Plus, the last but not the least is expense. It is 3 to 5 times more than your simple tablet. One strip of morphine costs, I think, 30 or 40 rupees, while one patch for 3 days is about 1,000 to 1,500. So please remember all these in this thing. The pharma companies push the sale of patches, while simple opioid tablets really do make a difference. Okay. There is some other question. If a patient is already on high dose morphine for pain, becomes breathlessness, can we increase the dose or it will cause? So this is the question. This is very important because very often the patient is already high dose of morphine. If he gets breathless, then there's some other reason for the breathlessness, which is more acute, like probably a PE. So in such situations, increasing the dose does not make sense. We have to go back to the drawing board and finally find out what are the causes for breathlessness. Sometimes it could be just anxiety. Sometimes it could be, bad news. Sometimes it could be acute, what do you say? Some other thing that has happened that has led to the increase. So you need to assess because there's no point increasing the dose for breathlessness. Breathlessness comes under control with just 20 or less than that of morphine. So please go back. Every patient is different. If a patient is already on morphine, you can probably increase by 25%, but there's something else that causing the breathlessness, which is not just because of the underlying integration. So for example, there might be pleural effusion. So you can drain the pleural effusion, right? Because if you're saying a patient is already on high dose morphine, it might be typically for cancer pain. So there might be other reasons for the patient to be breathless. Okay. So with this, am I okay to move on? Yeah. Okay. So one other very important and very sticky topic to discuss is terminal breathlessness. Now, terminal breathlessness is not just for patients with respiratory symptoms. Patients with cancer, patients with cardiac, patients with renal, patients with motor neuron, patients with respiratory, towards the end of life, almost 90% of patients experience breathlessness. In an incurable condition, we need to keep the patient comfortable. I think all of you must have heard about the famous statement of Dame Cicely Saunders, where the manner in which you lose a loved one is etched in the memory of those who live on. So, not just for the sake of dignity and respect for the patient, but also for the caregivers, it is very important that the patient transitions in peace. And that is what we mean by aggressive control of breathlessness, which is also called as palliative sedation. Okay. Here, what we use is in opioid naive patients, we give 10 milligrams of morphine along with 10 milligrams of midazolam continuously as an infusion subcutaneously, like how you take insulin under the skin. So, palliative sedation, the intent is to comfort. The intent is not to kill the patient. Yes, however, the doctrine of double effect, you're trying to do something good. The flip side is that the patient will die. This needs to be discussed in patients who have COPD, ILD, who will go through a respiratory depression or respiratory failure towards the end of life. It has to be discussed, it has to be documented. You need permission of the patient and the caregivers. Typically started when the patient is actively dying, so not able to maintain oxygen, breathless, probably obtunded, usually not given for more than 24 to 48 hours when death is imminent. right? Important to recognize active dying. And this is only given so that the patient transitions in sleep. So patient becomes unresponsive, patient is actually sedated, and then the patient dies in the sleep. And that is a huge comfort, not just for patient, because if you talk to patients who are in that situation of worsening, declining health, they are already thinking about death. They're already thinking about, they know that they're going to die, but what they're scared of is the manner in which they will die. Will I choke? Will I be breathless? Will I be alone? Will I be like a fish out of water? So all these things, see, we don't ask patients these questions. That's why we don't know. If you ask patients and if you sit and discuss with them, you'll realize what all they're going through. We are so focused on physical symptoms. We are so focused on cure, cure, cure. We forget that two-thirds of the conditions we are not able to cure. Any thoughts before I go to the next symptom, and then I'll finish it in 5 or 10 minutes? So cough is another important distressing symptom, especially even though it's protective. When it's persistent, it can be really, really irritating. And what else is cough? Remember, it's not just from the lung. It can be the ENT, it can be cardiac, it can be gastric, it can be drug related, it can be radiation. And in some children, it can also be attention seeking or psychogenic. So history, again, very, very important. Again, non-pharmacological, lifestyle changes, early dinner, small frequent meals, propped up position, walk after dinner, all these things are important. Acupressure, acupuncture, and then the medications that you give for persistent cough. Now, obviously, you need to check all the pathophysiology for underlying lung conditions like asthma, COPD, etc. But one of the recent papers that has come is morphine for intractable cough and interstitial lung disease. So that has come as a landmark paper only last year. You can start with codeine, again, not available very easily and causes constipation. So please give laxatives. Uh, in ILD, you can use morphine like you use in breathlessness. And another interesting medication for refractory cough, we don't know why, you've evaluated everything, patient is constantly complaining, is gabapentin. You can use with 100 milligrams in the night because it also causes sedation. Patients benefit with that so that they can have a good night's rest. And we don't go beyond 600 milligrams for gabapentin. Then coming to pleural effusion, as we had discussed a little earlier, when you have recurrently filling pleural effusion, especially in a malignant situation, you really need to focus on the prognosis. If the patient's prognosis is good, we can put an indwelling catheter. If the patient's prognosis is not good, we just aspirate one time and then we treat patient symptomatically with morphine. So please understand, if the patient is good prognosis, we can drain the fluid, we can do pleurodesis, we can abolish the pleural space. But the patient's prognosis is not good and patient is not willing, we should really listen to the patient and do what is in his best interest. And then last, of course, is hemoptysis. Again, you must remember, it can be very, very scary. We as doctors need to prepare patients for if they can be a good high risk for getting hemoptysis, because this is one thing that you cannot look after at home. Usually patients with hemoptysis don't die of blood loss. They actually die of drowning in their own blood because they aspirate the amount of blood that they cough out. So please remember, when you send these patients home with a cavitated tumor or a tumor sitting next to a blood vessel, you should explain to the patient the contact numbers of places where they do these difficult invasive treatments like bronchial artery embolization, lasers, ablation, brachytherapy. This cannot be managed in any hospital. It has to be tertiary hospital with expertise available. Okay, so this is important. And last point I would like to make is the pandemic and the palliative care. We cannot forget those 2 years we all sat at home and it affected all of us, not just doctors, not just patients, just the community at large. And if we doctors were trained in palliative care, we would have probably triaged better, selected patients for the ICU better, decided which patient is doing well and which patient is not, and given them comfort care. We didn't have ventilators for everybody in the COVID pandemic, and we could have selected patients better, and most important, handled grief, bereavement much better, because we had lots of families where multiple losses were seen. Doctors have died during the pandemic. There was so much loss of life and livelihood. So I think a basic training in palliative care is essential for all healthcare professionals, not just doctors, in PG as well as in undergraduate, it's extremely important to realize that we are doctors to help patients. Without patients, we would not have a profession. So we need to align ourselves with their wishes so that they have a better disease experience and their whole care is literally taken care of. It has to be holistic, because I would really like to remind all of you that you and me are health care professionals, not health cure professionals. We really need to focus on the care of the particular individual and not just focus on cure, 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 save, save, save. With that, I will end and over to thoughts, discussions, and the case.
Thank you very much, Dr. Rajam. See, with the question what they asked, no, about other than morphine, I think when you have something which is very simple and easy, straightforward, this will be the best, and they will have to see this being used rather than the sustained release is used a lot. Lost is.
But I don't get sustained release in Bombay. I get only immediate release. So my request is read about morphine. Watch, if you can, get a hands-on training in any palliative care unit or NGO. Watch how it makes a difference. Convince yourself and then start using the medication. And I was same like you 7 years ago. I never thought that morphine could make such a difference. But we did a trial of ILD patients about 1 year ago, where we realized that almost 80% of my patients were on morphine, and of them, only 70% of patients died at home. I only got a message saying patient has died peacefully. Hardly any hospital admissions for interstitial lung. And also, we could actually improve their quality of life. And they were on morphine for 8 to 9 months before they died, enjoying good quality life. See, you and me are not God to make the disease go away. But at least you and me can be a good support and a friend to patients to improve their quality of life, to be able to enjoy whatever is left, right? So that is very important. There is no this thing for quantity of life for anybody, for you, me, nobody. But quality is important, and that is what we need to focus on. Unfortunately, our training is so grueled on survival, grueled on duration, and we forget how irritating it becomes for the patient to be dependent on caregivers. How to manage cough in CA, oropharynx, and hypopharynx. So again, you can try, if it's a dry hacking cough, etc. You can try with codeine, then you can try with morphine, and then if the patient is not able to sleep at all, then you can really try gabapentin. And some non-pharmacotherapy also works, like acupressure, acupuncture. It's just that as allopaths, we are so blocked in our thinking that homeopathy is rubbish, Ayurveda is rubbish. The point is, when we don't know about it, we shouldn't be trashing it. Yes, we should find out if the patient has faith. You should try it, because at that stage in life, anything and everything works if you have the faith, right? Because they're anyway in the phase where they're terminal. So please encourage the patient, speak to their Ayurveda homeopathy doctor, find out what it has, involve in your patient care so that the patient also knows that the doctor cares. So that is very important to communicate.
In this front, no, I can just say, like 4 or 5 months ago, I've seen a patient who was CA, but she had like with her CA, she didn't have pain as her main issue. When she started having pulmonary she had secondaries in many places. At that point, breathlessness was her main issue. She was looked after by her daughter, and she was doing everything. This patient I've seen in Pallium during our home visit. So we had added 2.5 milligrams, and first they had added her, and I saw her after 5 to 7 days or something like that. She and the daughter felt so much better. Now she's able to sit and eat her own food, and she just walks to the toilet by herself, which she couldn't do before. She was only on 2.5 mg TDS. So we said either continue or add one more 2.5 depending on your comfort level. And that made a big difference for her. She was stage 4. They knew the diagnosis, prognosis, everything was known both by the patient and the carer. And so like this, no, and we have all used this for umpteen patients who are on constant oxygen. when you start on them, two things you'll see. First, they will feel the relief or benefit, and they'll be comfortable without oxygen for some time.
Also,
So these things.
one thing we forget is the caregiver burden.
Mm,
Imagine a COPD patient who's been looked after by the family for 10 to 12 years. And if the patient becomes increasingly difficult and breathless, it becomes more and more dependent. There's a lot of compassion fatigue. The caregiver has to stop going to work or cut corners there, look after so many things. He cannot focus on his family, his life, his career. There's so much going on in the family when you have to be the caregiver for a patient with a chronic illness. So at least if the patient is able to do his own activities with less supervision, with more comfort, it's a huge relief for the caregivers also. And palliative care looks after patients and caregivers and addresses their health related suffering, which is so very important. I'm sure a lot of you are caregivers to your parents or grandparents. It is not easy emotionally to be invested and then looking after them, taking to the bathroom, changing them, showering them, seeing to it that they're safe, they're not aspirating. So many things are going on, and it's not easy at all for us to do what we want to do and look after our loved ones. So it is difficult. Somebody's asked about, I think Dr. Anuradha has asked about steroids. Now, please
mm.
remember, if the underlying pathophysiology is like an airway disease, then steroids makes a difference, or an acute exacerbation of interstitial lung disease, where there's acute inflammation. See, steroids is the best anti-inflammatory we have. So when there is an inflammation, yes, you should try the steroids. But what I am talking of is chronic breathlessness syndrome. What you are talking of is acute respiratory distress, in which case you should use all the medications that the patient has an underlying pathophysiology where you think there is an inflammation. But it will not take care prolonged use of steroids is not going to take care of your chronic breathlessness. For that, you need something which acts centrally, which is also an anxiolytic, which reduces the respiratory rate, because the lung is in such a stage that it is really very bad and you cannot retrieve it at all. So therefore, steroids has a role when there is an acute on chronic in any condition, but not for chronic breathlessness.
So the same thing only see when someone asked, when someone is on high dose morphine and see, always at any point of time, the diagnosis is what helps you to go ahead with your management. So if in doubt, you have to go back and then see. So and then that sometimes it could be an emergency, it could be an entirely new cause for it. And this morphine for breathlessness, because see the pathology you need to know, and then the mechanism by which or how this morphine is going to act. So when with chronic breathlessness and the rate is so high, so now having had this session, you will know why and how it is working, and so then that is what will be helpful. So understanding it and using appropriately and seeing the benefit will give you confidence to use it. There will be lot of retaliation. Still, as Dr. Rajam is telling, many are not willing. Even if the patient is struggling like that, you say, then either the patient or the family will tell, no, no, morphine is not required for me. Why are you giving me something which is not required? As she said, not in pain, no cancer. So they don't believe us. So that is when, if it comes from a physician or their regular person who looks after them, will make the life easy for the person and give better quality of life.
Shall we move
I
on to
think,
the case?
yes, can we move on? That's what. Sangeet, can we go on with the case presentation, please?
Okay, ma'am. We have a case presenter is Dr. Abhay. So, do you?
Please go ahead.
Hello, good evening, everyone. Am I audible?
Please go ahead. Yes, you're audible. Please go ahead.
Sure. Uh, there's very interesting case, ma'am. We had one 77-year-old female patient who was diagnosed with dilated cardiomyopathy with moderate tricuspid regurgitation, aortic regurgitation, and pulmonary artery hypertension. She has chronic lung disease, bronchiectasis, diabetes mellitus, and severe anemia. Patient presented in the OPD with chief complaints of cough, shortness of breath for since 1 week. She is not able to go to the field. She's not able to work properly, and she is having some low grade fever, fatigue. Uh, there was history of previous this thing admission with severe iron deficiency anemia. She came to us 2 weeks back. Can we have the next slide, please? So she was admitted previously. She came with an HB of 5.7. During that time, a chest X-ray was also done, but we couldn't find any lung pathology as such. There was no history of any cough or any breathlessness. We had an iron workup done. Iron workup was done, and she was found to have some iron deficiency anemia. There was stool occult blood was negative. There was no symptom or any signs of any occult blood loss, and we discharged her off after 2 blood transfusions. She was getting better, following which after that, she had this history of cough, breathlessness, sort of other symptoms. She had a previous history of old TB sequelae also, for which she got treated. Treatment was done for full ATT was completed, ma'am. Then CT was done for her. So we planned another CT, and we also sent you sputum CBNAT. So the sputum CBNATs were negative, but her CT reports they showed that she has an ongoing some fibrobronchiectasic changes in the right upper lobe with partial volume loss. And there was fibrotic stance with septal thickening, some fibrotic patches in the left upper lobe, and there was dilated pulmonary artery. So this patient was admitted. She was having type 2 respiratory failure when she came. Her saturation was only 51%. ABG was done. Her bicarbs were really high. I mean, PCO2 was really high. She was on ventilator for a good 1 week, following which we couldn't really assess this lung pathology, ma'am. Like we wanted to get one MRI done, but patients were really were poor to get this thing, I mean MRI done. Uh, on examination, yeah, she was having 51% saturation, and there was all bronchial breath sounds were present, astaxis was present, carbon dioxide retention was looked. Uh, can we have next slide? Yeah, the next slide. Yeah, so her main concern now, so she was treated for the same. But the thing was, ma'am, her saturation even after the treatment was usually below 88%. When she was in our ward, her saturation during the nights used to go around, drop even down to 60s, to sometimes even 50s. She didn't look very tachypneic, or no, there was no symptoms, like no signs or any symptoms of any breathlessness or any sort of any respiratory distress, but her saturation used to drop like to 60s to 50s. So we kept her on long-term oxygen therapy. She requires some on and off 2 liters to 4 liters of oxygen daily. So I really wanted to discuss these psychological aspects. She's really fond of gardening, and she's not able to cope up with what like her daily activities. She's not able to go to the fields anymore, and her daily activities are impaired. Her main concerns were she was feeling sleepy, and she really likes to work. Plus, the cost of all these medications and oxygen cylinders, they are another costs for her. And another thing was it was very difficult for us to explain her condition to this patient. So yeah, summary is just this 77-year-old female. She's diagnosed with bronchiectasis, diabetes mellitus, pulmonary artery hypertension, dilated cardiomyopathy. She's in long-term oxygen therapy, and her main concerns were impaired daily activity. She feels sleepy while doing work. Uh,
Something is wrong with Abhay's connection. But thank you very much, Abhay. We can see the discussion points on the slide. And thank you for bringing out a non-cancer condition. Most of the time, it's always a cancer patient here. So thank you very much for actually thinking of a non-cancer. So if all of you can put your minds together and list out the issues with this patient, starting with age. So I go with age, which is 77. What else are the issues of this patient? You can type, no problem. So she's 77.
Type or unmute and speak. Whatever is convenient, it's fine.
We can stop sharing because we know what the discussion points are.
That's what, exactly, Sangeet. We can come out so that we can see
Yeah,
everyone.
so she's a diabetic, which is incurable, and diabetes is itself has a lot of issues with respect to small artery disease, etc. Yes, she's severely anemic. 5.7 is definitely a cause for breathlessness. So she's anemic. Then she's had old TB, and old TB, heel TB, results in a lot of airway disease, small airway disease, which results in pulmonary hypertension. And therefore, what was the most important thing that was missed, like I told in my presentation, is pulmonary function test. We don't know where the anatomy of the issue was. CT scan is done. CT scan shows some bronchiectasis, some fibrotic, which could be heel TB. CT scan is not going to show the functioning of the lung. We really need a lung function test here, and that should have been done when iron blood was given. We should do a basic lung function to know whether it's airway, whether it's parenchymal, whether it's reversible, irreversible, all those small airway, large airway. So yes, cardiomyopathy is the other thing. And we didn't have a 2D echo. So we needed a 2D echo because that can contribute to breathlessness. We need a lung function to know which part of the lung is affected. And most importantly, at the time when she came with 5.7 and she was not able to do so many things, etc., that is the time to integrate palliative care. Let the volunteers, the social workers can look after the money. Volunteers can explain to the patient what exactly is wrong. Psychologists can tell the patient that, let's discuss your worry, anxiety, and physiotherapists, because if it's bronchiectasis, that means a lot of secretions in the lung. You really need to do postural drainage to remove those secretions. You need that acupella to force those secretions out. You need hydration to make the secretions thin. Then you need proper diet. It's not blood transfusion you give 2 times and send the patient home. He'll come back with iron deficiency anemia. You need something which is long. So all these aspects need to be looked after. And at 77, yes, she likes to work. Therefore, we need to have a balance. What is it that she enjoys? Okay, you like gardening. We focus that she can do gardening. Then we can actually help her with a long tube and oxygen concentrator. So the oxygen concentrator can be in the house and the tube can be outside in the garden. So she works with oxygen, because it's important for a person to have, with pulmonary hypertension, it is the strongest indicator for long-term oxygen therapy. It's not that the person should desaturate, because a low oxygen is a potent vasoconstrictor. So pulmonary hypertension, in order to prevent escalation, is long-term. So there are multiple things one could have done with this patient. First and foremost is a proper set of investigations. Investigations which include, like I said, PFT, echo, why the iron deficiency anemia, correct the iron deficiency anemia, involve psychologists, involve physiotherapists, get the sputum out. If the patient had a PFT which showed reversible, inhalers would have helped. Now, obstructive sleep apnea, I don't know I don't know her weight, snoring, etc. Typically, in a patient with all these symptoms, they might not be obese, but yes, they can have central sleep apnea. For that also, we can do an overnight oximetry, because this patient was dropping oxygen during sleep. So we should give this patient actually 24-hour oxygen with all the other inputs. So I think investigations, we need to go full. We need to be sure of what in the lung is contributing to this. And sometimes when we say that patient didn't look breathless, patients get used to that breathlessness. So they don't complain because they don't know what is normal. They don't know what it is to breathe 12 to 16 breaths per minute, because they only breathed 25 breaths. So for them, that is normal. So when you say patient is not breathless, is it with this so your respiratory rate, which was missing in your examination. So these are the things you need to finalize. First is the history taking. Second is the proper evaluation along with the proper set of investigation. I don't think a CT repeat was merited. And I have another issue here. There is nothing like a routine examination. Examination, investigations should be, there has to be an explanation why you do this. It cannot be routine. Cholo, it's available in my hospital. Let me do everything. That doesn't make sense. Is it applicable to my patient? Why did you need to do a repeat CT? You could have done a lung function test, which would have attributed you much more information than a CT. Okay. So it's not pointing mistakes. It is here. You and me are here to learn. And if your hospital doesn't have a lung function department, it is very important, probably as important as a CT scan department. Maybe revenue generated by CT is more than PFT, but it doesn't demerit the use of a lung function test. So please remember that is all very important, and early integration. Now, if you find a patient not able to cope, something is amiss, then you need to sit back and think, what is bothering you? There could be something in the family. She must not be getting food to eat. Nobody must be giving her food. Everybody must be eating the rest of the food or whatever. You don't know. So these things can also cause anemia, correct? And another thing, in bronchiectasis, there's something called as anemia or chronic infection. So if patient keeps getting infected, they will have a low hemoglobin. So you need to treat that by sputum culture sensitivity, to give them the proper antibiotic, postural drainage so that they don't keep getting infected. Yes, Dr.
Sundaram has, you
has
can
raised his
unmute and
hand.
speak, Dr. Sundaram.
Good evening, madam. So far going so good. It's all possible in a place, I mean, tertiary care hospital, whatever we have been saying so far, like pulmonary function tests and other investigations, even echo. But in a remote area in the patient's home or in a palliative care setup in a remote area, how to go about doing all these investigations?
So one thing is you can get simple lung function, portable lung function tests. You can have it in your dispensary. If you don't have, you can do a 6-minute walk test. Just make the patient walk for 6 minutes at his own pace. Meaning you mark 2 points in your clinic, 100-meter or on the road. Ask the patient to walk, measure the pulse oximeter. Now every Indian has a pulse oximeter after the COVID pandemic. So you measure the pulse oximeter, see if the oxygen levels drop. When there is a desaturation in the oxygen, it's a great indicator that this patient needs to be on oxygen. Yes. Now the next question is, how are you going to get the oxygen? That's a good question, which might not be possible. Then in which case, if you have a hospice or something, this patient needs to, because clearly then if you're not able to provide oxygen, this patient's lifespan and quality is going to be less. But there are methods of finding out which patient needs oxygen therapy, even by this simple pulse oximeter. Second thing, overnight, you can put the pulse oximeter and see if the patient, when sleeping, when the patient drops oxygen, that is also an indicator that he needs oxygen through the night. So these are the things that you can do. Yes, you don't need to do an echo. But if you have an ECG which shows tall P wave, that means the patient has pulmonary hypertension. And pulmonary hypertension is an indicator for long-term oxygen therapy. I appreciate the challenges, but I feel even in a tertiary hospital, sir, they don't do these investigations. They go straight for imaging. Imaging doesn't give you function of the particular organ. You need to do the right tests. And according to the rural district hospital, etc., therefore, it is important that we get these basic investigations into the district hospitals instead of focusing on other things. Like, for example, ultrasound is important when you are having a pregnant lady. Similarly, I think pulmonary function test, basic. You don't need the fancy plethysmograph. Basic handheld you get these days, which is important.
This peak flow meter, is that available
Peak flow
easily?
meter is something for asthma. Typically.
So,
that is a thermometer
then
for asthma.
what is that the one that is easily available that they can
Have
assess?
a portable device which is less than, I think now it must be around 50 or 60,000, which can be kept in every hospital, which you can do, which gives you FEV1, FEC, FE1 by
Okay.
So
That's all. So that, because just basic, that
which will help
FEV1 by FVC will be enough to get an idea of that
will
1 minute.
Whether it is airway, whether it is parenchyma, whether it is
Obstructive
reversible,
or
whether it
restrictive.
is large airway, whether it is small airway. That much you can get. So yes, I appreciate that in unfortunately, our rural area, It's not as developed as a tertiary, but even in the tertiary, people really jump to X-ray and CT and keep repeating CTs, which I completely don't understand.
No. So generally, we say you ask for investigation which will alter the outcome or management of that particular patient. Only then your investigation or your writing of investigation is
When we used to
justified.
practice case presentation for MD, when we said routine blood tests, the first thing that the doctor used to say, what is routine? Why should you do CBC in a patient of COPD? So you should know the answer why you should do. Similarly, there has to be a logic in writing the test. Simply doing test doesn't make sense. I hope
And
I've
see, you have
answered
Thank you.
a little bit of
you
your
have
doubts.
to you have to
Yeah.
keep in mind the financial condition also. See, you have to see what is that will help, what is the investigation will help in the outcome. So see simple best for the patient. You have to look at multiple factors and then see sometimes if it's not in your place, what is the nearest place will be having or something like that. And
It's
always
not going to
rule
change
out.
the outcome and the management. You should really not do it. You should spend more time in looking at the patient and improving the patient's quality of life, especially in rural, remote areas when investigations are less. So, Abhay, have you taken the constructive criticism positively?
I think he was not there and he has come back. Can you answer,
I
Abhay,
am
please?
here. My network is not that great in
No
this
problem.
place.
No worries. No worries. Could you follow up? I saw you joining back. So that's where I thought, so you are back. So you have gone
Yes,
through
ma'am.
and
So I wanted to just clarify that the CT was not done in the hospital. We don't have a CT machine here in the hospital. He was sent to the district hospital with some money from the hospital. So we provided some funds from the hospital to help the patient to get to the
My
diagnosis.
question is not about how the CT was done. My question is, did you need a CT? Or would a lung function have benefited more? Because you could have started inhalers on this patient. Because typically,
Yes,
both TBC
he's
equally will have
he's
small airway disease.
he's on inhalers, ma'am. He's taking formaldehyde. He's taking hello.
Yeah,
yes, go ahead.
we can
Yes,
hear
ma'am.
you.
He's taking MDIS, formaldehyde, MDIS, Tavova, two puffs, BD and OD, like that. He's also
And
on
technique
dieters.
has been checked. Is it through the spacer?
Sorry, ma'am.
Technique has been checked. Are the meter dose inhalers through spacers or directly in the mouth?
With the spaces.
So all these things make a difference. I have an asthmatic at home who improvises her own technique every time. So we have to check that. We have to teach the caregivers how to give this inhalers. So
Yes,
just
ma'am.
writing the inhalers.
We kept her for 2 days just to check her technique and everything, so that we don't send her off with oxygen. But since her saturation was not improving, that's why she started on long-term oxygen
We
therapy.
need it because of a pulmonary hypertension.
PhD.
And the other thing, Dr. Abhay, is physiotherapy, very important. Postural drainage, removing the sputum so that she doesn't keep accumulating and getting infected because that's what is bringing her back to hospital.
Expectorating, teaching them to expectorate and
Postural
get rid of
drainage,
the
the
secretions.
chest percussion, huff puff, so that they can remove the secretions towards the main airways and bring it out. So small things make a huge difference.
No,
Yes, I
many
know
times,
lots of
no.
it cannot be done in a small place, but at least if you have the knowledge, you can teach the patient, to lie down head low. If it's upper low, then the patient should be lying head low to bring out the secretions. So you need to know if it's left lung, the patient should be lying on the right and bringing out the secretions. So all these things are important. These are simple things that we should all know, especially when we are in a resource crunch place.
No, only thing, no, these things, one is awareness, next is time. I know this all takes time, okay?
So that's
First, you
why
should be,
palliative care.
correct.
That's why
See that.
palliative. You are all busy
No, that's,
consultants. Please wear your palliative care hat to identify which patient needs more time. Integrate with palliative care, shared care. It's not that you don't have to follow up on that patient. At least you know what's happening so that you have the time to look after others.
no, that's what, see, equally important also. What is the point of doing you're treating a patient if you're doing insufficient, no? So that is where all of us have to start to think. Maybe these type of patients you can see on some other day. See, one day in a week you can see patients who needs extra care. See, little bit of a tailor making your own approach. So everything works. See, like all of you will you should start thinking in such a way. You can make or fit all this within your armamentarium also. Not that these are impossible. And this postural drainage, everything is known. Putting science, physics, everything into our own medical practice. So that's what, see, all of us know physics, okay? Nothing what we say, and when we say, no, this gravity, postural drainage and all of us know, not that we don't know. We have segregated. So as we accept other specialities, no, when initially subspecialties came, it would have been different. Again, now this is also another specialty to integrate. Either if you are willing to work together, well and good. Both will benefit. Your palliative care also will benefit, and you will also benefit. So in turn, you also learn more things, and you can also help your patients. That's all.
Anything
else?
Thoughts or suggestions,
that's what. So
feedback, please feel free. Thank you very much, Anuradha. Anybody else wants to share some experiences, anecdotes? We have about 5 minutes. We can do it.
And Abhay, also, are you happy with everything? And so that overall you got an idea.
Yes, ma'am.
Thank you.
The next follow-up, I'll try to get the physiotherapy also in touch with the management.
Very important. You know, because
yes,
once the patient gets more independent, you also will automatically realize, Abhay, tomorrow, God forbid, you have a fracture or, so for some reason you have to lie on the bed and you have to ask somebody else to change you, somebody else to feed you. It is extremely undignified. You feel stripped of your dignity. So the more independent you are, the better your mental health is. So similarly for our patients, if she constantly has to take help of people, she is going to get demoralized. And how do you improve that? Is both by counseling. So you can also ask, are you coping, not coping? See what her answers are. And then sometimes the fact that you ask the patient the question itself, the patient is happy. At least the fact that the doctor is asking about my welfare. And if you incorporate pulmonary rehab, it really makes a difference. So thank you very much for the case. I really appreciate it. Usually it's a cancer case. And I always hope that somebody presents a non-malignant or basically a non-cancer, because it's important to integrate into non-cancer also. Thank you so much, all of you. Have a good evening. And you all can go back to your cup of tea or leisure time.
Thank you very much, Dr. Rajam, Iyer, as always. See, these are important issues which people have to know the nitty-gritty of thing, and something coming from a person like you will be very, very helpful for them. So thank you once again. Over to you, Sangeet.
I have my own vested reasons for people, because I want all of this young people to integrate palliative care and see that when I need palliative care, I have somebody to give it to me. So thank you very much.
Thank you, ma'am. Thank you for your wonderful presentation. Thank you, Radha, ma'am, for facilitating the whole sessions. Thank you, Dr. Abhay, for bringing up the appropriate case. Thank you all for joining. Thank you. Let's see in the next sessions. Bye.
Thank you very much.